All right. Good afternoon, everyone. Welcome to episode 2 of Masters of Balance. My name is Taylor Schalk. I'm a physical therapist and a board certified orthopedic clinical specialist, and I'll be your host for today. I'd like to welcome Thomas Buckley, a biomechanist, athletic trainer, and the University of Delaware's Concussion Research Laboratory lead. So in this Q&A, we will dig into his extensive knowledge gained from over 150 publications and 20 plus grants pertaining to balance and the effect of traumatic brain injuries on body systems. So Thomas, welcome, and thank you for joining us today.
Thank you. Happy to be here.
As we get started today, I just wanted to remind everyone that this is a live Q&A session, so please submit any questions for us in the Q&A feed section at the bottom of your screen, and we'll address them as they come in. So with that, I guess we'll dive in. So Thomas, very few conditions in the realm of movement health garner the attention both in research and in the media quite like traumatic brain injuries, particularly concussions. So through your professional lens, can you tell us a little bit about where we are at right now in terms of current concussion identification and management?
Sure. That's a pretty loaded question. I'd go on for an hour, but I'll try to keep it brief here. There's a kind of infamous quote that goes back to the 1920s that says, at this point in time, it's unknown. We are not able to know whether or not there are severe long-term effects of concussion. And here we are about 100 years later, and we still kind of have the same question. We don't really know. Certainly, some people have bad outcomes. There's really no question about that. But many people have concussions and bad outcomes. As far as acute management right now, I think we've come a long ways in the last decade or two. We've come miles in the last decade. So can you follow my finger and what score is it? To a pretty complex, multifaceted assessment right now that includes some brief cognitive screens, balance testing, obviously, vision, and symptoms. That's quite accurate. And so if you have a qualified healthcare provider who's well-trained in concussion management, the ability to identify a concussion in real time is something we're pretty good at. I think the real challenge we have right now is identifying when that person's actually recovered.
Mm-hmm. Absolutely. And a big topic that seems to come up frequently, particularly in sports and in performance, is the importance of baseline testing. And how close are you to your baseline? Is that a measure of if that athlete or performer is ready to go back to their sport? So how important is baseline testing, and how has that school of thought evolved over the years?
Sure. Much like the previous answer, we went through a phase where there was no such thing as baseline testing. There was no such thing as concussion management, really. It was just go back in the game. So baseline testing really started in the 1990s with some pen and paper neurocognitive tests, and it was purely neurocognitive. There wasn't any other assessments going on. And then gradually over time, we've added in the other assessments. And so I think we've seen that grow quite a bit. For a while, neurocognition was really considered to be the core. In fact, at one time was called the cornerstone, and it certainly plays a key role, but I don't think it's really thought of as a cornerstone as much anymore. But as we moved along, the idea of baseline testing, it's very simplistic and makes sense on the surface, right? Let's compare Joe to Joe, and that way we compare, we know exactly how they're doing. The challenge we have is, for example, I'm at the University of Delaware. We have about 600 to 650 student athletes in a given year. And we baseline test all of them when they come in as freshmen. So that person could get a concussion a week later, a month later, a year later, or 3.5 years later. And so if we think about for ourselves, if we're being honest for ourselves, when we were 18, we might be a little different when we're 20 or 21. Hopefully we're smarter, having spent 3 or 4 years in college. We probably have better balance because we've been working with strength and conditioning professionals for 3 or 4 years. And so just how valuable that baseline test is, varies, because that time interval between the baseline and the subsequent and the injury plays a big role. So the study that came out of the CARE Consortium, and so briefly, the CARE Consortium was the largest concussion study done in the world. There's 30 schools in the United States. We were one of the sites. And we baseline test all student athletes and then check them again following concussions, use standard protocols. So it's about 65,000 baseline tests and about 6,000 or 7,000 concussions in that database. That's an amazing number. And what we found in that is if you did the baseline in the same season, you were more accurate to diagnose a concussion than if you did the baseline in a prior season. The challenge of that is that sounds great on paper and it sounds great on ESPN and the New York Times. The challenge is we have 650 student athletes at University of Delaware. Each baseline test takes between an hour and a half and 2 hours. You do the math. That's not very efficient. And that's at a school that's a research school with a research staff, with graduate students, the whole works. How is Joe Smith or Jane Smith, the athletic trainer out at local high school, ever going to do that? They can't. So that raises the question about normative data. And generally speaking, normative data, if the population has been well studied, and so that would be really high school student athletes, college student athletes, and the military, normative data does pretty well for identifying the presence of concussion. And then if you have an atypical population, so if you're working with people under the age of really 14, especially under 12, or if you're older than 25, there just isn't good data out there right now. In fact, one of the bigger findings that came out of the Amsterdam consensus meeting was our data on the 12-year-olds is almost non-existent. And if anyone there is a parent or works with young people, I have an 11-year-old son. I think he grew 1.5 inches last week. And so he no longer has any balance whatsoever because he grew 1.5 inches last week. And they change at that in those ages, 5, 6, 7, 8, 10 years old. They change very rapidly. They change very inconsistently. And so you would then probably need particularly frequent baseline assessments on them. And so I think that's, kind of the challenge there. In terms of what you do in the baseline assessment, really it's multifaceted. Symptoms drive most things. We have to keep in mind that a lot of people have symptoms at rest. If we were to ask all the panelists on here, does anyone have a headache today? Is anyone tired today? Anyone having trouble focusing because the speaker's really boring? Then you would certainly potentially get some yeses and some scores there. Are those concussions? Hopefully not. They're just part of life. So we'd be careful about relying just on symptoms. And then there's neurocognitive testing, brief screens. There's balance testing, the current clinical one that I'm sure we'll talk about as we go along here. Vision testing, vestibular ocular testing, reaction time testing, all kind of goes into this.
So for maybe a smaller school, or maybe a school that has 1 or 2 athletic trainers to several hundred athletes, if they have one short brief scan that they just completed that at a more frequent pace, would that help increase the sensitivity of that test for them then? Or do you think it's better to have a larger battery of tests?
I mean, it's a trade-off, right? So ideally, yes, the full battery multiple times is the ideal situation. But again, even here with a large resource staff, we can't really reliably do that. It's just not feasible for us. And it's also not feasible for the athlete because you're talking about 1.5 hours to 2 hours every year. They don't want to do that. And so that's the challenge. So I think really trying to get at, something that's quick, to the point, but also informative. And that's kind of trade-off that we try to get to for what's kind of best testing available.
Right. Now, going along with that, and the fact that concussions are multifaceted, so we diagnose them and look at them from a variety of different body systems. Could you tell us a little bit more, maybe for some of us who might not be quite as familiar with concussions or TBI management, could you tell us a little bit more about the symptoms of a concussion and what different body systems are affected by them?
Sure. From a symptomatic point of view, the most common is headache. In fact, when I have a new concussion patient come into the clinic, the first question I'll typically ask them is, how bad is your headache? I don't ask, do you have a headache? I ask how bad it is. And I make them deny it. And that almost never happens. We're probably higher than 95 or 98% with headache. Those who claim no headache almost always claim no symptoms at all. And they're always miraculously football players who can count to 7 because that's when they know they need to be able to be symptom-free to turn to play next Saturday. And so headache is certainly the most commonplace. After that, you get really feeling in a fog, not feeling quite right is certainly one. Very common one. Person might feel a little off balance, like they don't quite feel like they're stable on their feet. You certainly have sensitivity to light and noise. You'll see them walk in, baseball hat on, sunglasses on, looking down as they walk. Their gait will be shuffled. And so that classic presentation. In fact, we oftentimes jokingly refer to concussion acute diagnosis is your friend who went out and had too many diet root beers last night. That's how they look acutely. And then the day after or a couple of days after a concussion, that's how your friend looks after the morning after too many root beers. And so, we see that's what we see mostly is that initial presentation. In terms of balance disorders, certainly that will be present. And what we found is that the more you challenge a person on a task, the more balance deficits you'll see. So again, that's going to be very dependent upon what your population is. I work with collegiate student athletes for the University of Delaware. We don't beat Florida and Michigan in many sports except field hockey. But nonetheless, our athletes are still very high level Division I athletes. They're in the top 1% of physical performers out there in the country. And if I give them a complex balance task, the first time they're not very good at it. The third time, they're excellent at it. And so that learning curve takes place. And so being able to challenge that person with a very hard balance task, and at the same point in time, a task that doesn't have a big practice effect, goes a long ways and really help to discriminate that. So, for example, the most common test that's used, the best test, the balance error scoring system. A lot of people on the call might be familiar with it. It's 3 stances: dual stance, single stance, and tandem stance. You hold it for 20 seconds, your eyes closed on both the firm surface and the foam surface, and you count the number of errors that occur. And error is really any deviation from kind of a static posture. Almost every student athlete will make errors on the single leg foam and the tandem foam. They're next to impossible to complete the first time through. You take a student athlete, a high level student athlete, and they do that 3 or 4 times, their score is going to cut in half, and lower is better. So they might go from a 10 or a 12 at baseline. They'll be down to 3 or 4 by the third time you do that test. They're too good. Their nervous systems are extremely well tuned. They have the ability to take in some out of sensory feedback and apply that, and they get really, really good at these tasks. And so I think one of the challenges we see is that the balance error scoring system, it might be okay for that acute assessment where the person is concussed like 10 minutes ago or maybe an hour ago, but past that, the value of it goes down a lot, especially in your athletic populations, because they learn the test. And so that's why we've tried to grow some other stuff I think we're going to talk about here in a moment. That's a little more challenging for the person.
Tell us a little bit more about the different higher level, more challenging tasks that you use to try to account for that learning curve.
So one of these we've done a lot of work with is gait. And now gait is not particularly challenging, so I'm contradicting what I just said. But what we have in gait is we don't have a learning effect. We learn to walk average 12 to 15 months of age, give or take. Our gait starts to stabilize around age 5 or 6 and tends to stabilize pretty good about age 9 or 10. Of course, there's some variability in that. Those are averages. By the time they get to high school or college, the vast majority of people, their gait pattern is very well set. I don't know about you, Taylor. I don't stand there on a single foot, barefoot on a foam pad, my eyes closed very often during the average day. So I don't really get better at that task. I do, however, walk a lot. And so, we all got to get our 10,000 steps in, right? And so my gait pattern is pretty well established. And so what we do with the athletes is we do gait testing with them. We use portable accelerometry. We actually use off a cell phone. There are apps out there. People can contact me if they want to. I can give recommendations on them. I don't work for any of these companies, but that's a different story. But there are cell phone apps right now that for $5. And that's the actually maybe it's a $10, but $10. You can buy the app and it'll do real time, moderately complex gait analysis for you in an individual. So it's very cost effective and it's very user friendly. You don't need a full 3D biomechanics motion capture lab. I'm a little sad about that. That's my background, my training, and I put a lot of markers on people over the years. So that's single task gait, which is we just had them walk about a 50-foot hallway. It's a quiet hallway. There aren't many people. They walk up and back a few times. We're able to take those measurements and get really good data on that. To make it more complex, what we do is dual task challenges. So we apply cognitive challenges to them while they're walking. So we'll ask them to do months of the year backwards, count backwards by a given number, serial sevens, spelling words backwards. It's always kind of fun to see. You can almost predict the person's major based on how well they do on them. So the engineering majors, you tell them subtract by 7 starting at 108. Within 5 steps, they're almost at 0. It's like, okay, you're doing pretty good. The idea there is you really don't have a learning curve to the gait. And then when you add the dual task to it, we see especially acutely Or either have cognitive or motor prioritization. Most people will cognitive prioritize. If you're in a quiet, safe environment, they're not going to prioritize their motor tasks because they don't prioritize their cognitive. They want to sound smart. They want to be answer the questions right, and so they'll slow down their gait patterns. And so you'll see a shorter step length. You'll see a slower gait velocity. You'll see an increased double support time, increased stance time, decreased swing time within the cycle, as they really slow down to focus on answering those questions correctly. And so we do with that, we look at both the motor scores, really how they're doing with their gait patterns, and we also look at the cognitive outcomes. And then the cognitive outcomes, we do two things. We look at a number that they get correct. And so if I give you, again, serial 7 starting at 100, so you go 93, 86, 79, 72, 65, etc. How many did you get right? And as well as what percentage you got correct. And the reason why those are both important is that person on a 50-foot walk could answer just one question. So I say 100 minus 7, they say 93, and they stop answering and keep walking. Well, they got 100% correct. That's not really very representative of a person who goes all the way down to, to 23 and gets one question wrong. And so is 11 out of 12 better than 1 out of 1? We typically say yes, because they kept pushing through on that. So we look at both of those. And then again, we typically see a cognitive prioritization where they focus on getting the answers right. We typically see 90 to 95% accuracy at baseline. Acutely post-injury, that will drop down to about 80%. And then by the time they return to sports, probably closer to 90 and 95%. But what we're looking for is, as that cognitive performance returns, does the motor task remain impaired? So that's kind of what we look at there.
Yeah. And I know as physical therapists, a lot of times with our standardized outcome assessments, we really like to have a cutoff score. So especially when we're looking at falls and falls risks. So if you're rehabilitating an athlete and you're doing a cognitive motor task like that, is there a cutoff score in terms of the percentage of difference between their baseline and where they're at right now, where you might be able to say, I think this athlete might be ready to go back to sport?
That's a very challenging question. That's a work in progress. Minimum clinical difference scores of 0.09 meters per second is one that you'll see a lot in the literature for a person being impaired in general. 1.2 meters per second minimum gait velocity speed is a safe, healthy gait. We've noticed a very substantial white coat syndrome, especially at baseline, where otherwise healthy students will walk fairly slowly. And so you have to actually encourage them. A lot of times we don't count the first trial because, again, there isn't that Hawthorne effect or white coat syndrome, whatever you want to call it, where the person is like all of a sudden they're walking really carefully. And so I think what we really look for in the gait ones is the relationship back to their baseline, as well as, do we see gait velocity numbers that are what you would expect, 1.3 minimum, ideally 1.4-ish meters per second, with a 90+% cognitive performance. Keeping in mind that it's really not uncommon to see people struggle or not do as well on one or the other. That engineering major who ripped off 13 consecutive -7s in a row will then turn around and may struggle on their spelling. They won't do bad because, most college student athletes are smart people, but they won't do as well, and they'll be slower, and they may only get 4 or 5 words spelled correctly over the course of 20, 25 feet, as opposed to getting, again, 13 or 14 -7s in a row. And so we don't have established cutoffs. There's a large paper in British Journal of Sports Medicine written by Fiona Butner, with David Howell as a senior investigator on it, where they were working on that some. There's also there's a fair amount of variability between the lab assessments that were used. Some used motion capture, some used portable accelerometers, so they weren't quite able to come up with nice solid numbers like that. And at the end of the day, we talk about physicians all the time. I'm a researcher primarily. I'm an athletic trainer originally, but now I'm a researcher. I tell physicians all the time, don't let the test be smarter than you. As an experienced clinician, you know what you're seeing in front of you. Is that gait correct? Is that person compensating? What's their body language? What's their facial expressions? How are they moving? Is there fluidity to the movement? And so we have to remember that as humans, we have to still be smarter than our test until AI takes over and we all just disappear.
I hope that doesn't happen. In
I
terms of
spent too much time on Twitter, apparently.
what'd you say?
I spent too much time reading Twitter on all the AI
Don't we all?
doom and gloom.
So after a clinician is able to identify that their athlete has had a concussion or that there's a disparity between what they see in front of them and what they would expect, or a difference from their baseline, what are some good strategies then for rehabilitating that person?
Well, I feel like I'm repeating myself here a bit today, but a lot's changed in the last 20 or 30 years. So back when I started practicing in the mid-1990s, it was, well, first of all, let's go right back to play. And we got out of that mode. And then in the early 2000s, we started to shut people down. And so the idea was, and you look at the early position statements, it was rest in a quiet room, minimize screens, don't watch TV, keep off of this. That might be good advice in life for all of us at this point. But, and then what people found very quickly was, well, that's not very good. Take away a high school or college kid's phone for an hour and see what the stress response is, let alone for days. And so we realized that what was oftentimes called cocoon therapy was simply ineffective. I mean, it was, be in a quiet room, don't watch TV, don't talk to people, don't be on your phone, just rest. Whatever you do, don't think about your concussion and how you feel. Obviously failed. And so about a decade ago, the work started coming out. We were fortunate to contribute a couple of the papers ourselves, but there's been a number of papers out. And John Letty at the University of Buffalo has really deserves the majority of the credit for this. But he said, no, let's get people moving again. And so we started to see the idea of getting involved in cardiovascular exercise as we work our way through the recovery process to improve outcomes, and they've been successful. And so I think we see our transition where it was, okay, wait till symptom free, then start exercising more aggressively. And then it kind of progressed to wait until the person's symptoms start to go down. And I think now we're at a point, you look at the last consensus statement that just came out, and the idea is, no, that person can start exercising within the first day or two. But again, we have to be smart. We're not going to have them go out and do a 10-mile run on day two. But there's nothing wrong with getting out of the house, getting out of the apartment or the dorms, and going for a walk, doing a bike ride, things that are symptom tolerated and don't get much worse. And so right now, on a scale of 0 to 10, the general recommendation is if symptoms don't go up by more than 2, then the person continue to do that exercise. And if they do good today, we continue to increase it tomorrow. And a lot of this comes back to clinician really being there and being attentive to what's happening in front of them. We've seen plenty of athletes who are turning green, who tell us they're fine, there's no symptoms. And you start bringing the vomit bucket over because they're about to get sick, but they're insisting they're fine. And so that's when you as a clinician need to step in and really kind of reel them back some on what's happening. So again, right now, for the physical exercise, the aerobic exercise, pushing the people to a symptom threshold, not increasing by more than 2 from where they were, is safe, it's effective, it is now recommended as per the last consensus statement. So the other thing is, okay, that helps a lot of people, but then as clinicians, we can look at our patients. Are they having vestibular problems? And so if you're assessing a person, you're identifying vestibular deficits during your evaluation, well, physical therapists have a technique called vestibular rehabilitation. It works. What a surprise. Vestibular rehab works on vestibular symptoms. If a person's having cervicogenic symptoms, well, we know how to treat cervicogenic problems. And you work your way down a list there. And so if you treat the symptoms present in front of you, that can also be very effective at reducing the person's overall symptom burden. Kind of a never-ending discussion on medications. If you go online, you'll find every possible imaginable new medicine that might work. We won't make fun of a person too much, but Russell Wilson came out with his concussion water that was extra oxygenated. And you can kind of insert your own science joke there, right? But we know those don't work. Omega-3 free fatty acids, there might be some advantage there that's probably not going to hurt you. It probably doesn't help too much. The controversial one really is sleep medicines. If you're a patient is struggling with sleep, should you have a physician prescribe sleep medicine? That kind of goes back and forth right now. For those who do support it, the idea is for any of us who have ever gone through a period of time where you don't sleep well, you feel like crap. I know it's not a particularly scientific terminology there, but and people who've had children who have newborns will certainly tell you all about that. You don't sleep well for a few days in a row. Now add the poor sleep to a concussion, the neurophysiologic concussion, that will compound itself. And so if you're able to get the person to sleep better, even with the sleeping medication, that might start to kind of reverse a lot of those symptoms that are building on themselves. But aerobic exercise, highly recommended. Treat specific symptoms that are present in front of you. And then also the other thing is we want to try to avoid over medicalizing. As I mentioned to you earlier, the first thing I say to a person is, how's your headache? And we're doing a symptom assessment. It's not uncommon for us at all to have the person have 3, 4, 5, 6, 7 symptoms, mild to moderate burden. If you're familiar with the Grayson checklist, it's 22 symptoms scored 0 to 6, with higher being worse. So the overall score is 0 to 132. The average person at rest is probably a 3 to 5. Again, that goes back to, does anyone have a headache right now? Anyone tired, etc. And so we frequently see scores between like 25 and 40 acutely post-concussion. And so after we do that, one of the next commentaries I often have with the patients is, yeah, that's normal. And guess what? In a couple of days, you're going to feel better. And we always couch it correctly that you should start feeling better, and we expect you're going to start feeling better in another day or two, as opposed to over medicalizing and catastrophizing, which we're trying to avoid in these cases.
Right.
That's kind of a long-winded answer there. I apologize.
No, all good. And, kind of building off of that, going along with that, I'm sure the first question that most athletes or coaches have is, when am I going to be back? How long is this going to take? And I'm sure that's also a difficult question to answer because everyone is so different. But is there a general or baseline expectation of when you might expect an athlete to be able to go back to their sport?
This is one area that there's been a lot of improvement really in the last 5 to 7 years. And so as you really look at what predictors are there, we thought for a long time women did worse than men. And in the CARES consortium study, we actually didn't. The timeline's both the same. One thing, so what does predict delayed recovery? Initial symptom burden is really your biggest predictor initially. The person who has a lot of symptoms acutely post-concussion is probably going to be the person with longer recovery. Beyond that, some of the things that generally go in that direction are like if you have a history of migraines, if you have a history of psychosocial disorders, these tend to get exacerbated by concussion and prolonged recovery. Non-contact athletes tend to recover a little slower than contact athletes and collision athletes. We don't know if that's because of the way they're treated, maybe that they're more conservative with tennis players and runners than you are football players, where a concussion is a normal part of the sport. Where a tennis player getting concussion is atypical, to say the least. Well, hopefully it is. If it's not, that's a different story. And so I think we look at some of those predictors as what's going to be there. How long? Average person symptom resolves in about 3 to 7 days if you're high school to college age. And then if you follow the guidelines as you should, it's another 6 to 7 days of progressive return to play protocol. So we're looking at probably an average right now of something between 12 and 16 days return to play for the typical person. That said, there's a big study that came out of CARE Consortium that gets a little bit miscited nowadays, where they say it takes about a month on average. And it's not a month on average. It was that about 90% of athletes in the CARE Consortium will recover within a month. So I think you say within a month, the vast majority of people will be. There'll be a small minority of participants who will go on to persistent post-concussion symptoms or syndrome. But the vast majority will get better. You'll be about 75% at about 16, 17 days, give or take, for return to play time.
Does multiple concussions play a role in that, or have an effect on what you would expect or how you would manage those patients?
It's interesting that's been intermittent as a predictor, and there's been studies that have shown absolutely yes. There's also studies that have shown no. I think part of it, this is more an opinion than an evidence-based statement, is the person who's had a concussion before sometimes will be able to kind of know what to expect and do better because, okay, well, last time I felt lousy for 3 or 4 days, so I know I'm going to feel lousy a couple of days, and I know I'm going to get better. And so that positivity plays into it. Is there an increased neurophysiological vulnerability? Probably. When does that occur? We don't know. How much does a person's pre-existing neuroanatomy and genetics play into that? We don't know. And then we talk about prior concussion history. That assumes, probably incorrectly, that we can actually ascertain what their prior concussion history is. Really, just identifying how many concussions a person has had can be very, very challenging. You look in the literature, that's a very unreliable number. There's a lot of different ways of asking people that question. If you look in the long-term literature, you'll find extreme numbers out there. There are studies on later life athletes who will self-report 4, 5, 600 concussions, who are former football players. So it really comes down to, how do you define concussion? How do you do that? How do you define that with the student athlete? What we try and do is we give them a very general definition of concussion. We emphasize that it does not have to involve loss of consciousness or post-traumatic amnesia or memory loss. We'll use phrases like, how many times you've been hit in the head and then not felt well, etc. And then sometimes we get an absolute number, sometimes we get a kind of an iffy number, and then, we'll kind of interview and walk our way through. Well, tell me what happened. Okay, you get hit in the head playing football. How long do you have symptoms for? What else is going on? And that allows us, we think, to have a relatively accurate assessment. But obviously, the older that person gets, the harder it gets, because they've had more exposure to really identifying how many prior concussions they've had. And so that's really a surprisingly challenging, hard number. If you just ask your patient how many concussions have you had, I'd have very little faith in that answer, because I think a lot of people think concussions have to be knocked out or knocked silly. I think we've all seen the video of the football player who lines up on the wrong side of the ball. Right? There's one team in red, one team in white, and the guy on the team in white is lined up next to all the guys in red. Well, that's kind of the obvious one. It's the kind of funny one. But that's very atypical. The vast majority of concussions have no loss of consciousness. They have no obvious post-traumatic amnesia or balance deficits. And so they're much more subtle than that.
Gotcha. Understood. That's interesting. So I know one of the things that we have chatted about before is that, a lot of times the heavy emphasis is on that acute injury in the here and now. Like, let's get that athlete back to sport, get them back to their previous level of function. But what we don't really talk about a lot is then, what does that athlete look like 15, 20 years down the road, maybe after they're done playing their sport or they're later in life. So how have you seen those concussion-related balance deficits impacting older adults' quality of life and their other comorbidities that they experience?
Sure. That's an area we're actively working on right now. I know some other sites are as well. A lot of the work that's been done has been neurocognitive in nature. And clearly, neurocognition is important. If you don't have good neurocognitive ability, that's going to dramatically adversely affect your quality of life. Our perspective on balance is really gets back to something you mentioned earlier with fall risk. We know how devastating falls can be to a middle-aged and older population. I assume everyone on the call here is probably an AT or a PT, and so we know the stories about falls with hip fractures and nursing homes and hip surgeries and not going home again, and a very high mortality rate from that. And so what we're trying to look at is what's kind of driving. So are those balance deficits there, and if so, what's driving it? And so right now, what our current research is showing is that, and we just had a paper published a short time ago, in rugby players who are in their 30s and 40s, so still relatively young, says the guy older than that now, who are actually playing rugby. And so most rugby players in the US don't start till after college. And so rugby is a great sport for us to look at, because both men and women play it, and the rules are the same for both sports. It's the only true collision sport that women play. And if you ever watch rugby, it's not for the faint of heart. It's a pretty substantial injury sport with high injury risk, including a very high concussion risk. And they actually did pretty well. It was quite interesting that these active rugby players in their 30s and 40s, most of their scores, both in balance and in other measures, were pretty much as good as the runners, which really surprised us. We thought the runners would be the healthiest and the best grouper overall, and these people getting hit in the head a lot wouldn't do as well. Where it starts to change when you get over 50. And so once these people start over 50 years old, you probably lose some compensatory strategies. You probably have, we know about sarcopenia. There's going to be some muscle loss with aging. That can be offset with continued exercise to some extent. But the simple fact is, a 50-year-old is not a 20-year-old. A 60-year-old is not a 20-year-old. And so we do start to see balance deficits there. We see gait deficits. We see dual task gait deficits start to creep in the 50s. And so what we started to do is we use a virtual reality approach where we put them in an immersive environment where we can manipulate their visual, vestibular, and somatosensory systems. And so we'll alternate the feedback coming back from the feet. We'll put a vibrator on the Achilles to alternate that to affect that somatosensory feedback. We'll put vestibular stimulation on that will affect their vestibular processing. And the fun part is we'll angle the screen that where they're walking. So one of the paradigms we have is you look like you're walking down one of the hallways of the Death Star. And so the stormtroopers walking by and everything else. And you're on an instrumented treadmill. And so we can speed up or slow down a treadmill, and we can tilt that the Death Star a little bit. And we can tilt it to the point where it's not perceptive to you. It's a 1 degree angle, it's a 2 degree angle. So you're not able to perceive that difference. And then we can also then change the refresh rate and the frequency rate of the actual screen projecting in front of you to challenge your visual systems. And what we find is as these adults age, especially if they had a concussion history and or more concussion history than repetitive head trauma history, both concussion history, they become overly reliant on their visual system. And so they start to downplay the somatosensory and the vestibular and become over reliant on visual, which is not a totally atypical response as people age. The challenge becomes your visual system becomes overwhelmed. I'm here in Newark, Delaware, I can walk down the street, it's not too bad, but all of our 25,000 college students coming back this weekend. And so all of a sudden, walking on Main Street with a whole bunch of college students around, now you have a lot of visual stimuli presenting themselves to you. Well, think about walking around any major city in the US, trying to get on or off a subway, on or off a bus in busy environments where there's a lot of visual processing to take place. And if you're over reliant on visual, and you aren't using your vestibular and you aren't using your somatosensory systems to give you feedback, that's more than likely going to increase your fall risk, increase your balance deficit. And so I think this is an area that we're doing some work on and we need to continue to work on. And I probably don't need to convince the people on this call that reducing fall risk is very important.
Yeah, absolutely. And what have you seen in terms of that cognitive and behavioral component as a result of either multiple concussions or down the road from a major concussion?
This is the most controversial part of the last consensus statement. It's extremely controversial right now is what the answer to that question is. I think I kind of probably come down more middle of the road. There's really little doubt right now that if you play a long time in a collision sport, and by the way, that includes soccer. We tend to put a lot of emphasis on football, but in several studies in soccer have shown the same thing. And it's really a dose-response relationship. So the more you play, the more often you hit in the head, the worse you do later in life. There is good evidence of a 2 to 4 times elevated risk of neurodegenerative disease. So that's Alzheimer's and related disorders, mild cognitive impairment, and things along these lines. Parkinson's is a little bit iffier. There was a study that came out a couple of weeks ago that said elevated rate of Parkinson's, but the methods on that were pretty weak. It wasn't a great sample. It was all a sample of people with Parkinson's. But there's been excellent work done by Willie Stewart over in Scotland, most notably, has clearly showed an elevated risk of neurodegenerative disease. But at the same time, a lot of these studies have also shown that people who play these high-level sports, football, soccer, etc., live longer and have less other comorbidities. So they're less likely to have cancer, they're less likely to have many other diseases, and their overall mortality rates are lower. And so you kind of get this balance of you might live a longer, healthier life, but you do have an elevated risk of neurodegenerative disease. And so one of the big studies in soccer showed that in Scotland, they have a universal healthcare system, so it's easy to access medical records and have good population normative data. And the exact age escaped me right now. I'm going to guess is probably in the 70s, but hopefully no one quotes me on that. And there's a 6% dementia risk in this population of non-athletes. And the soccer players or rugby players, there's a 9% risk. So that's a 50% relative increase, 3% absolute increase. And so you have to ask yourself, you have to ask the people around you, is that 3% elevated risk worth, the lifetime of playing collision sports and the other health benefits come with it? So you might live longer, you might live healthier, but you're also likely to have an elevated risk of these neurodegenerative diseases. So how do you weigh that?
Right.
And that's a complex question, right?
Right, exactly.
And,
Are there any activities or behaviors that tend to be a little more neuroprotective, especially for people in that population?
yeah, and it's going to be exactly what everyone on this call already knows. Eat well, exercise, be social, be active. There's the Lancet Commission came out with 12 modifiable lifestyle factors that are associated with dementia-related disorders. It accounts for 40% of dementia risk. So again, you can reduce your risk by 40%. Um, all the negatives are what you think they are. Excessive alcohol intake, smoking, diabetes, heart disease, high blood pressure, hearing loss, social isolation, and things along these lines. And that if you, and these are all modifiable. And so if you reduce those modifiable risk factors, you are probably then going to be able to reduce that risk of the later life. Now, if you've had injury to the brain while you're younger, we're not going to undo that. But if we keep otherwise healthy, eat well, exercise regularly, we will help reduce that risk moving forward.
That's awesome. And not just switch gears necessarily, but going back to that recovery process and how do we know when our patients are recovered or ready to go back to what they were doing before? What are some different management techniques for patients who maybe they're not getting better or they're having prolonged symptoms or they might be getting worse? So what are some of the best ways that clinicians can handle that?
Sure. So that's an ongoing challenge. I think, a little bit what I talked about earlier, I think the aerobic exercise is showing a lot of effectiveness right now in post-concussion syndrome patients. And so for the terminology there has changed recently. We probably all went to school was probably called PCS, post-concussion syndrome. Now it's, the vernacular in that's probably not real accurate because post-concussion means the concussion is over, but the concussion is not over because they still have symptoms. And it's oftentimes referred to now as a persistent concussion symptoms. Typically, it means it lasts 3 or more symptoms, more than 1 to 3 months, depending on which definition you use. And so that person comes to the clinic. A lot of times, what we look at, again, can we identify a underlying issue that's driving this? And so this is where we see vestibular pathology be very commonplace in those participants with those patients with long-term issues. As I mentioned earlier, physical therapists are very effective and skilled at treating vestibular deficits, dysfunction. So you do your relatively standard vestibular rehabilitation. That tends to be quite effective. The exercise part is very effective. There's different, oftentimes referred to as phenotypes of concussion, and one of them is really a psychosocial phenotype. And so things like cognitive behavioral therapy, so that's not something a physical therapist is going to do, but we can help facilitate referral to a psychologist in the area. And cognitive behavioral therapy has shown some effectiveness at reducing symptom burden in people with the psychosocial side of it. And so largely what we're looking at is, receiving treatment helps, and identifying kind of, if possible, what the underlying issue is. So, vestibular ocular really does drive a lot of that. Think about how does your headache feel if I wear contacts, so if my contacts are dirty or just need to be changed out, I'm gonna have a headache by the end of the day just by looking at my computer screen all day. And so if you have an underlying neurophysiological reason why you're having vestibular ocular deficits and you're trying to be back at work, trying to be back at school, then that certainly poses challenges. It really does bring up one of the bigger issues I think physical therapists are probably more on the forefront here of, which is, I mentioned earlier, roughly 90% of all concussion research is high school, college athletes, and military. Yet they make up a distinct minority of the actual concussions that occur in life. So many concussions happen from bicycle accidents, car accidents. We oftentimes refer to them as late night disagreements, oftentimes located in close proximity to a bar. To the much more serious things like interpersonal violence. And so that's a population that's usually not 14 to 25 years old and is not as resilient necessarily as that 14 to 25-year-old is. And we really don't have a great handle on how that 35, 45, 55-year-old person responds. Particularly, we look at a person who's in that age group who has other comorbidities and perhaps has lack of health insurance or limited health insurance or lack of access to health care. and or maybe they have health care, but they have a job, a physically demanding job, which is an hourly worker, where if you don't work, you don't get paid. And even if they have symptoms, they have to go to work because they have to be able to make money to take care of themselves and their family. And that's where you really start to pose a substantial psychosocial and physiological problem here. And so, we try and think of this as a biopsychosocial realm, right? There's a biological side, there's a sociological side, and there's a psychological side to these conditions. And for the athlete, Saturday's game is the most important thing. It always is. But for the 50-year-old worker, getting his paycheck at the end of the week might be the most important thing, and being able to take care of themselves in that regard. And so, those balancing and challenging demands of, do you have access to healthcare? Do you have insurance that covers healthcare? And do you have time to get there? Do you have the ability to get there? Do you have transportation to and from where you're trying to get to? I think these are the patients that physical therapists are probably seeing in clinic that we don't have a lot of great data on. If you have a 20-year-old college soccer player comes in, there's good data on that. 50-year-old dock worker, there's really not good data on it.
Right. And given that population of people they might not be seeking care for a variety of reasons. If they're coming to us later in life with chronic pain or like CPRS or CRPS syndrome, those individuals, it might be worth talking to them about what kind of injuries have they had in the past that might contribute to it, and something like a head injury that you might not think is related to what's going on in front of you. That, do you feel like down the road that could certainly be something that is contributing to the manifestation of other musculoskeletal symptoms?
Certainly possible. That's the whole person approach, right? We've got to look at we're treating a patient, not an injury. And so, who's this person? What's happened to them over time? What's underlying it? And again, I think we are in a very bad spot trying to understand that in this middle-aged to older adult population. And even as a person who has done a lot of the work in the college population, we have disproportionately treated a population that's actually probably least in need of it. Those otherwise very healthy 20-year-olds, yes, Saturday soccer game is important to you. It's an important part of your life right now. And we don't want to devalue that, but it's also, again, not the same as that person that you're just describing who walks into the clinic, who now is 50 and has a whole assortment of other problems that occurred because of what happened when they were 20. And so, again, that's the direction we're going in right now. I think it's the direction a lot of people are going in right now, and it's really an area that we need to do a lot better job of understanding. So as researchers, we can give feedback to you as clinicians, because say, hey, this is what works best in that 50-year-old person who walks in your door.
Absolutely. So I'm going to ask a question from Q&A here. So in your experience, what, besides the app that you use to look at that acceleration with gait, are there any other technologies that are your go-tos or that you find to be the most valuable for you?
So again, for us, it's always a trade-off between feasibility and data. So we will do some studies with people. We'll bring them into the biomechanics lab. We'll do 3D motion capture, EMG, force plates, the whole work. It's a 30 to 40 minute setup. It's a hour and a half total process a day for the person. So that requires the people available to have the technology available to you to process the data in a timely manner, et cetera. So clinically, we actually use tandem gait a lot. We recommend tandem gait as a clinical tool. I don't know why I didn't mention that earlier. Tandem gait is exactly what it sounds like. It's walking heel to toe for 3 meters, turn around, walk back. And you time the person, so your only outcome measure. It used to be the hard part. Used to be having stopwatches floating around the clinic or the office everywhere. Now we all carry our own stopwatches on us, and so that's actually been a very effective tool. That's clinically very easy to use. We do that. We'll do that single task and dual task. Another balance assessment we'll use. So we'll use force plates. So we'll have a person stand double limb, single limb, eyes open, eyes closed on a force plate. Again, now you're talking about a cost potentially being cost prohibitive for a lot of people. A force plate is going to cost you 10 grand plus or minus. You need the technology to analyze that data. We've used portable accelerometry. There's a couple systems out there. We use one called APDM out of Oregon Health Sciences. It's 6 little opals that you strap on, Velcro straps onto the person, have them walk, we'll give you real-time feedback. So I think we've used a variety of those. I have a personal preference, and it's a long-standing argument with a couple of my colleagues, that dynamic movement is a more accurate assessment for post-concussion than quiet stance. There's certainly an argument in both directions. Naturally, I think I'm right. Why wouldn't I? And you come to quiet stance. I mean, you look at that, your very original concussion assessments were the Romberg. And you hold a Romberg for 20 seconds. If yes, you pass. If no, you fail.
Yes, certainly our technology and how we look at health and movement has come a long way. And I think that's something that I've seen even just over the last year or two has picked up a ton of speed, especially in physical therapy, in outpatient medicine, that how can we leverage the data that we have into meaningful information that helps us take care of ourselves better, but also take care of patients better and learn more about how we can help them. So.
And I think one of the things we're working on right now across the board, and when I say us, I don't mean me. I mean, I think I'm a small piece of it. I think across the board, both researchers and companies trying to say, okay, how much data is sitting on my watch right now? Heart rate, step count, physical activity level for the day, how far did I run, what else did I do today? But how can we take this overload of information and break it down and have some outcome variables that are meaningful to a clinician and to a patient? Because yeah, I enjoy getting an Excel spreadsheet with 1 million data points on it from a force plate, but I'm not normal. I understand that. And processing and working in that data set is one thing. That's just not useful to most people. And so can we take this wealth of information that comes out and develop a couple of outcome metrics that say, okay, these are good ones, and the ones that make sense to us as clinicians and maybe make sense to patients. I mean, most obviously, which is what, 10,000 steps a day. Is there any magical about 10,000 steps a day? No, there isn't. We know there's nothing magical about that. But we know 10,000 is probably better than 9,000, right? 9,000 is better than 8,000. And so what can you do as clinicians to say, okay, well, we want to increase the physical activity level of that person post-concussion. Oh, you wear a smartwatch. So you did 3,000 steps yesterday. Can we go 3,500 tomorrow? Can we go 4,000 tomorrow? Is that 25% better? No, probably not, but more is more. And so can we use these type of technologies to continue to work to improve? And hopefully as we go forward, we'll be able to get better metrics where we say, it's not just step count, but it's consistency of steps first time sitting. It's what's the intensity level of each step you take. And is going for a 2-mile walk at night, but sitting on your butt the entire day as good as 4 half-mile walks breaking up your day. And I think we generally think that the breaking of the day is better right now, but even that data is not wonderful. And so being able to come up with data that's useful out of all the data we're getting is one of the challenges.
Yeah, one of the challenges, but I think definitely one of the most exciting. So I'm definitely looking forward to over the next couple of years seeing how the AI field continues to develop for the better, hopefully not to replace us, right? But
yeah, I say it jokingly. I mean, we're using machine learning algorithms to try and identify musculoskeletal injury risk. So we're part of the problem, probably, but it's there. We have to deal with it.
I think like anything, there's positives and negatives to everything, but I think the way that it's being used right now, I think it's got nothing but positive potential. So I'm excited to see where it goes.
Yeah, we just need to make sense of the noise.
Exactly. Well, Thomas, thank you so much for joining us. If there's any other questions, feel free to either ask them or you can always reach out to us post-session as well. But thanks so much to everyone who participated today, and I guess we'll see you next time.
Thanks very much for having me. I appreciate it.
Thanks. Bye.